معلش ارجع بس السلايد الأولانية
اوكي.
عشان بس يعني introduce yourself عشان ريكورد بس.
Okay. My name is Nabil El-Maleh, and I'm presenting today on tips and tricks for the exams. I've been through the international version of the exam. I passed in Dubai in 22, and I passed the national version of the exam a year after. So I've done a thorough preparation in both times, and I'll try today to convey this experience to you all and make the exam much easier, inshallah. How to learn and what to learn. I digged a little bit in the learning psychology. There is a very good guy called Jim Quick, and he had a few talks on the internet and a few courses as well. The learning process is short-term memory, retain, recall, which is long-term memory. So the much effort you do to recall or to recite the whole page or the topic immediately after studying is important, but also to retain and to recall whatever that decision or this procedure or this intervention at the exact right time at the right place is also another center in the brain. So you not only want to train your short term, you also want to train your long term. So how we can train our long term? Long term memory is information plus emotion. Yeah. So if you look back, you will realize that you remember all the weddings, all the funerals, all the sad times, all the happy times. If you just look into it, you could remember who you met that day, what you were wearing. You will have a lot of details. It's just because of that emotion was present. So when I thought about that, so how we can create that emotion while we're studying so that we can link our short-term memory with a long-term memory so that we can recall, retain whenever we need. You ask yourself three questions. Yeah. When you're going to use this piece of information, and how you're going to use it, and how you're going to teach it. Yeah. So when you're going to use it, why you need it, and how you're going to teach it. Yeah. And that create that visualization. Yeah. Like you create that emotion. It gives you a bit of a sense of responsibility. So you put a lot of attention in the topic. Yeah. For example, MTC, like the ATLS, the ABC. So how are you going to deal with it? A pelvic fracture or polytrauma in the E&E. So what's the first thing you want to do? Stop bleeding, airway, breathing, exclude life-threatening injuries. You just once you visualize that patient in A&E, a few people around them, you just like you are studying what you're going to exactly do. And the fact that you are studying with a purpose to teach what you're studying is also important, so that you have this ability to verbalize what you have studied. So retain, recall is very important. Put that emotion in every single topic you're studying. In the 6 months, if you got a 6 months, you need to make a plan to maximize the benefit, especially of your first half of the day, the time where you are in hospital. So time in theaters, time in clinics is very precious. Get one clinical examination, hand and wrist, and go to a fracture clinic focusing on doing a thorough, complete hand and wrist examination. Every distal radius fracture, you can examine the other hand. I did it. You can do it just to practice, because you need on the day to have this kind of very smooth flow in your examination. Time in theaters, try to get the list beforehand, read what you got on the list next day, dig a bit on research, and have a few discussions about the case on the day. and practice those habits. Just keep practicing those habits. Drawing, putting some notes, usually helpful, especially if you got those notes and you're just adding up to those notes. It creates a really good memory. You're practicing your memory because you're just having like a mind map or your own notes. So it's everyone got his own way, but I had like my own notes, and I found it very, very helpful because at some point you're just gonna skim and you don't really need to read it. So it's very good to have your own notes, even in these specific topics, so that it makes the revision of those topics easier. You can do your operative notes as well, usually putting some notes. This is the bit of emotion. So if you had a case that is common, interesting index procedure, just write a few notes, draw a few drawings, mention what was the theater setting, how was the surgeon planning to execute the surgery, the positioning, the tourniquet, where the assistant stood, what we used in this section at first, all those details, what type of K-wires, what type of plate, all those details would give you an edge if you needed to mention that procedure on the day. So especially on those kind of procedures that you don't see commonly, like if you haven't had much experience in pediatrics, so make sure that you write a bit of notes on DDH procedures or Perthes procedures, because they're quite common in the exam, but sometimes you lack the enough exposure. So get notes, take some quotes from the surgeons, because this will give you
ايه
an
هتعملي؟
edge on the day. I'll mute you, Rami. Sorry. Let's go to the scoring. There is a very different scoring system between the clinicals and the vivas. So you basically need to know which station are you in. Let's focus on how to get the 8s. So basically, in 8s, you need an excellent basic knowledge. Yeah, you need to know the breadth and the depth of the topic, and you need to provide supporting evidence to a high level. Yeah, so randomized controlled trials, meta-analysis, things like that. It's not required, but if there is a very obvious evidence for that topic, it will be expected to be mentioned. You need to be at ease with higher order thinking, excellent organization, logical thought, decision making, prioritization, management, data interpretation, and response without prompting. All that is kind of indirectly related to knowledge, but it's all about how you perform on the day. This is all about technique, when to say, or what to say, and when. So in Vivas, you really need to have this flow, this system to identify the X-ray, to identify the pathology, or either you can mention a differential diagnosis. And from this, you can start by telling your concerns. Like, for example, you find a pes cavus foot, an X-ray of a pes cavus foot, or a clinical picture of pes cavus foot. So this is a picture of a pes cavus deformity seen on exaggerated arch, hindfoot varus, a clawing of the toes, whatever. Describe the picture and say, my concerns is it unilateral? Is it bilateral? Because it may be a sequelae of a brain or cord pathology. I want to know from history, any family history, any history of brain injury, any history of trauma, onset of deformity, progression, because it could be a part of a hereditary motor neuron disease. It could be iatrogenic. It could be idiopathic. So just give a good introduction to tell the examiner, okay, this is pes cavus, but I got other concerns, especially if the if the picture or the clinical photo got some sort of a general or constitutional symptoms, like a radial club hand. You want to, my concerns is like renal, cardio, other congenital deformities. Just put that right away because it gives you that good impression at the start. Yeah. So have a good 1 minute of description and differential diagnosis, and also mention some concerns and things you need to know about the patient to start managing him properly. Yeah. And then you need to stop. This is not going to be prompting, but have a good 1 minute of giving, okay, I'm aiming for 8. Now the clinical. The clinical, in my opinion, it's a bank of marks. It's a bank of marks because if you look into the Viva curriculum, it's vast. It's vast. It's humongous. You can find books in arthroplasty, books in, but clinical, you can get a grip around the clinical. And unfortunately, sometimes we miss the clinical to the last bit, and then that shows on the day. I feel that the clinical is your bank of marks, and you need to get a very, very, very good grip of the clinical because it's very easy, much easier than the Viva. You need to be very good, excellent at history taking, and that means practicing. You need to take a thorough history taking. It's a bit difficult because most of the time you get a patient with a referral letter with all the examination in the MSK referral, or sometimes you skip all of that because you already know it. But as a candidate preparing for the exam, forget about that and start to create your own packages, your own history packages for a hip, for a knee, for an elbow, for a hand, and for a CP, a pediatric, for spines. Just have those packages well rehearsed in your mind. For example, hip pain, a patient coming with hip pain, the history of surgery, history of trauma, analyze the pain, VAS pain scale, what increase it, what decrease it, in and out the car, putting your socks, carrying your shopping bags, all the Oxford hip score, any associated symptoms, is there lower back pain, is there knee pain, have he done any injections in the past, have he done any interventions in the past, ideas, what do you think you have, any concerns, what's your expectations, and so on. Each joint should have a package that you are ready to fire. Clinical examination. An excellent clinical examination should appear like a dance. You shouldn't look a bit stressed or thinking about your next move, or imagine if a dancer stopped for a bit and thinking what's next. Yeah. So that's where the practice in clinic or practicing with your body is very important. You need to hold the hand. You need to have a patient or some of your family or a friend to practice those moves because it should appear on the day smooth like a dance. Excellent diagnostic skills to request the right investigations. Excellent respect, and this appears by your body language, your eye contact to the patient. Instills confidence, empathy, rapport, response to verbal and non-verbal communication, excellent understanding of ethical issues. This is all how you treat the patient. It's far away from knowledge. It's only how the examiners see you treating the patient. Yeah. And sometimes if you're stressed, it appears as if you're ignoring the patient or focusing just on getting positive findings without having a good eye contact and a good rapport and a good empathy with the patient. So try to give a lot of respect to the patient. Try to give eye contact, consent. consent before taking an examination. Like, I'll be examining your foot now. That may require me holding your foot in a different position. If it becomes discomfortable at any point, please stop me. Yeah. So at least if you're focusing on what you do and the patient give a grimace or, oh, it's painful, now you give the patient what to do in that case to stop you. Like, okay, it's discomfortable, it's painful. Because in the very unfortunate situation, if you examining the ankle or whatever joint and the patient did that or was in pain, this may decrease your marks significantly. So clinical just need a lot of personal skills, yeah, and this by practice shall come naturally on the day. I can't emphasize enough on delivery and confidence. If you are not a very confident doctor, you need to appear on that day as confident surgeon. Yeah. So you just need to practice on that. Yeah. Delivery and confidence is 2/3 of the exam. Knowledge is 1/3, but also the delivery, the communication, the confidence is very important. On the day, there is a lot of advice on what to do on the day, but I feel everyone got his own way of doing things. Um, we've been through a lot of exams, and you know what goes best with you. You can have a light breakfast, you can have a big breakfast, you can have just apples, bananas, you can have coffee, tea. Just do what you feel best on that day. The most important thing, like Ibrahim said, the self-talk. Don't talk negative to yourself because it may get you a bit down, especially between the two days. Many people ruined the Viva because they thought they have failed the clinical and they passed the clinical and they did the opposite. So self-talk is very important, but the good self-talk is the main thing. Yeah. So keep your spirits high, keep your heads high. Um, be very like a lion. Yeah. So be very confident. Be very um, um, humble as well. Like be likable. Don't be arrogant. Don't try to show off. um, but also try to have a high quality discussion, um, and let the examiners like you. Okay, keep eye contact to both examiners because both give you marks. So keep communicating with both of them, even if one of them is just asking the questions. Keep yourself hydrated, definitely. You can take a chocolate with you, take a piece between two sessions, um, or something like that, just to keep your mind running because it's very exhausting. Because your brain works significantly for a long period. And try to do the Viva courses because it puts you in a simulation event where you need to be present, fully present for 40 minutes, answering questions. So it's very, very important that you put yourself on the mock situation that amount of time so that you, on the day, it's not very exhausting or it's not very unprecedented. Yeah. Let's go to the exam. My way of thinking of the exam is you don't need just one suit for the exam, you need three suits for the exam. The suit for the intermediate clinicals, and the suit for the short clinicals, and the suit for the Viva. And they are quite different. For the intermediates, you need to be very thorough in your history. 3-4 minutes of history. Yeah, this is your time to shine, to ask about every single aspect that is relevant to this pathology. To be very thorough in clinical examination, take consent, spend some time to build rapport. Was your trip to here easy? How you finding the exam? Just break the ice, just to spend 3 seconds, 4 seconds to have a conversation with the patient. It wouldn't affect your time, but it will significantly increase your marks. And you need to be very thorough in management as well. In intermediates, they will give you x-rays, they will show you investigations, and they will have a discussion about surgical options. And it goes very well if you spend enough time in history and enough time in examination. You won't be squeezed in management. So imagine if you took the history in 2 minutes and you took the examination in 2 3 minutes. I'm done. I'm a very good clinician. I can know what I need to know like in 1 minute. And then you find yourself having 12 minutes of discussion. This is not where you want to be. Yeah. So take your full mark in history, take your full mark in examination, and have a decent discussion in management so that you get also a very good mark. In short clinicals, you don't need to worry about management. When you listen to the people's experience from past exams, many of them didn't go to the management, but the main thing is to fulfill the examination part, the clinical part, which is basically the diagnosis part. So your history, your examination, and not only examination just to go swiftly, but in thorough details, which means because there is no patient, you need to verbalize the exam, where you're standing, where your hands are, where is my right hand, where is my left hand, and what is your interpretation? What are you expecting? What are the different variants of the exam? For example, Galeazzi test. I'll be standing on the side of the bed, heels together, knees together, hip 45, knee 90. I'm looking for the side for femoral discrepancy. I'm looking for from the top for tibial discrepancy. Yeah. This is how you Thompson test. I'll be standing on the side, obliterate lumbar spine. I'll flex both hips gently, and then I'll ask the patient to hold one leg to his chest, and slowly I'll extend the other limb. And the angle between the thigh and the table will be the fixed flexion deformity, for example. So just practice to verbalize the test, because they will keep asking you, okay, where are you standing? What is the angle? Where the patient? If you made this right away, they will just trust that you're doing it the right way. In Vivas, you go very swiftly on history. Sometimes they tell you like ask 2 questions, things like that. But the idea of it that you get the very important, relevant questions in history, in examination as well, and try to relate your history and examination to management as you go along. And the Viva is a surgical exam, so expect that you will be asked about approaches, expect that you will be asked about surgical decisions, expect that you may be required to mention evidence. So clearly, this is the surgical exam, yeah? So you don't really need to be squeezed and waste time in history and clinical. Just try to tell them what they want to hear from history and clinical to pass you to the surgical exam to get 7 and 8. Yeah. A few tips for Viva. Description usually dictates your mark. This is where I said your introduction is very important. Take your time, spend the 3 4 seconds, look at the picture very closely. If there is a stick, if there is a cane, if there is loss of hair, if there is nail problems, if there's all of that should be mentioned if it's relevant. Anything in the picture that has any relation to the pathology, you should mention. And this is when you mention, okay, this is a Dupuytren contracture. If it's not very visible, for example, a hand like this, I'm concerned whether it's a radial nerve palsy or or a trigger finger, or like if there is a differential. If you're not sure, definitely give a differential. If you know the pathology, just hit on the nail. Tell them this is a Dupuytren contracture. I'm concerned about diathesis, which is a severe form of Dupuytren. I want to ask about family history, other ectopic problems, the age of the patient, and all the risk factors of diathesis. Yeah, so that gives you a really good start in Dupuytren, for example. Um, don't stare at the X-rays. Try to maintain eye contact with both examiners and keep a smile, even if you're stressed, even if you know that you're like it's your worst station, like you know that you will not do well. Just keep a smile. Don't make this be very obvious on you, on your body language. Just keep going, keep a smile. It's very good to be in control. Examiners like candidates who are in control, which basically let them go to sleep. Yeah. And how you get them go to sleep? If you run the Viva the same way they have their questions aligned. Yeah. Like if you're answering the questions while they are looking at all the questions without them having to ask the questions, you're getting an 8. Basically, you mentioned what is this differential diagnosis, why do you think this is, what's your concerns of this condition, what do you want to know from history, what do you want to know from examination, so that you can give the patient the right decision, whether surgery, no surgery, and if surgery, what type of surgery. Don't ask the examiner questions because they will make it up. And it's a very common mistake, and I usually see it in the mock exams as well. If there is a case and you start, is the patient diabetic? Is the patient on corticosteroids? Like, I want to ask if the patient on any blood thinners. Like, this is no go. Like, if you started to do that, the examiners will keep like making it up. If they are silly examiners, they will start like, oh, he got a bit of hypertension and he's on beta blockers, and he will take you away, far away, and just don't go that route. What do you want to do? Like, I want to know if the patient diabetic or not, if he's on corticosteroids or not, if he got any risk factors of that. I want to ask about age. I want to ask about this, and then explain why you want to ask. Because okay, if he's a young neck of femur fracture, I would like to fix it. If he's non-compliant or have a alcohol problem, I may think of a replacement. And hemi replacement to reduce the dislocation rate. Or don't go that route where you're asking the examiners questions, because they definitely don't like it. Swiftly clinical, thorough planning and management. Spend time to get your CT scan, to get more investigations before going to surgery. Don't rush in going to surgery if there is any planning required. It wouldn't give you a higher mark. They need to know that you're a safe surgeon. For example, you're not going to do a high tibial osteotomy without a long limb length views, for example. You need to assess the mechanical axis and your Fujisawa point, and where exactly you're going to do the correction and how much correction you need. Always answer the question. It's also a common mistake. Sometimes your brain tells you answer this part of the question because you're so good at it. So the examiner will ask you a question and you find yourself answering a different question just because you know it better. So don't do that. Even if you don't know the answer for this question as good as what you planned to answer, try to stick of what the examiner wants you to say. What is the question, and try to answer as best you can the exact question that the examiner asked. Yeah, because your mind will try to drift a bit or to mention evidence this is irrelevant and usually a waste of time if you're not answering the question of the examiner. Try to be relevant, show that high order thinking whenever possible. Don't say in a consented and a market patient, just add a little bit of fruit to that. So if it's a pediatric case, after consenting the parents of physical injury, possible deformity, limb length discrepancy, I would do that and that. In Dupuytren's, after consenting the patient about a recurrence rate, a risk of amputation, a stiffness, reduced function, I'll do that and that. Like try to say in a consented and market patient, but also add a bit of specifics to the pathology. Trauma marks are very hard, very, very hard. So it gets really intense. You should keep calm during the trauma stations, and you will be surprised that you did really well, but the marks is just like the excellent mark is 7 in trauma. Try to draw if you can. If there is a K-wire configuration, you want to draw a Kapanji, or you want to draw a the configuration of 3 lateral wires in supracondylar, or if you want to draw a tension band technique, the I-beam, or if you want to draw in the basic science, please do, especially in basic science, because it's a true evidence of your answer. After you leave, if they are borderline between 6 and 7 or between 7 and 8, those papers on the table would give you that edge, and it will make you more in a teaching mood, and will make a lot of your conversation easier, because you just relate to the visual illustrations in your hands. So it's very, very good just to practice that. Videos of Wang Wang is very good in that. So he just draws and explains while he's drawing. So try to get that talent, especially in basic science. You will get an unusual situation. You would get that situation, but keep calm. Don't say I don't know, but say my aim is this, my strategy is that. For example, my case was you had a medial epicondyle fracture, and while you try to fix it, it's exploded. It went into pieces. What you gonna do? And then I said, my aim is to restore the common flexor origin and to maintain stability. So my strategy is I will reattach the common flexor origin with an anchor and test the stability of the MCL. Yeah, so it could be a very out of the box situation, but try to make things logical. And what you want to restore function, how would you do that? What could possibly be in your bag of tools to deal with it, and just be calm and convey those thoughts. For trauma, it's hard marks. You need to let the examiner consider you as a colleague running the trauma next door without problems. Yeah, this is what they keep telling in the courses. You don't want to come across as not knowing what exactly you want to do, or not sure what you're exactly going to do. You want to come across as confident, and you speaking his language, basically. Never go back, carry on, always answer the question. I think we explained how that you need to always answer the question, but never go back here means if the examiner show you the x-ray and you spend a few minutes, and then he asked you, okay, what you want to do, what do you want to do, or what surgery you want to do. In this situation, answer the question and don't go back, because you may sometimes you say, oh, I want to take a detailed history, I want to do examination. At that point, you just, winding the examiner up. So if he asked you about a surgical question or a specific question, even if the viva didn't go through a detailed history or a clinical examination, again, it's a surgical exam. Don't don't take him back to, okay, I need to take history first. Like, just wait a second. I'm not going there yet. I need to take history first. I want to exam. This is not the right approach. Always, always, almost always answer the question. If they are asking you about what operation you're going to do, tell them what you're thinking about operation. Answer this question by telling, okay, in history, if the patient is like compliant and high demand and whatever, I would do this. If not, I would do this. Don't stop him and say, okay, I need to do a detailed history first. Don't offer evidence early. Just try to offer the evidence as late as possible in the viva, unless asked. If you've been asked about evidence early, say the evidence, but there is no use of the evidence at the very early of the viva, because they want to satisfy the basics first to give you 6 before giving you 7. Be ready for unusual scenarios. Draw if you can. Consent only specifics. We talked about that. In the when you're asked about approach, positioning, your approach, the incision, internervous plane, and structure at risks. Be very specific to be able to give the examiner what he wants. Don't go like retracted at this side and do this. Just be very, very concise. Position is that, approach is this, incision, my landmarks is those, between the internervous plan, structure at risk is that, this, and mention your aftercare. Just have something like 2 weeks in a back slab, then mobilize. I'll see him in 6 weeks, x-rays, and then I'll see him in 3 months' time. Just have this kind of ready-made plan, which is basically usually the same for most of the surgeries. But it just gives you that edge of like you've been satisfied the whole surgical event from the start to the aftercare. Clinicals, again, put on the right suit. You need to show skills. You need to show hand skills. In the shorts, you need to convey those hand skills by verbalizing where your hands, where you're going to stand, at what level are you looking. All those details gives the examiner how good clinician you are. You may say, I'll do Gileasi, I'll do silver skull test, but they will need to know whether you really know how to do it or not. So don't let them ask you questions. Just let them know. I'll sit the patient down. I'll sit on the floor. I'll cup the heel with my right hand. I will support the knee with my left hand. I will rest the foot on my forearm. I will take the whole ankle in full range of motion in dorsiflexion while the knee is extended, and then repeat that with the knee flexed and see whether the dorsiflexion would improve or not. If it remained the same, Achilles tightening. If it's improved, then it's gastrocnemius. So you now, like, despite the fact that there is no patient, but the way I'm describing it, okay, you know that I can do it. Don't worry about management. Don't try to jump to management. Try to satisfy their clinical questions first. Add how and why and possibilities. How you do it and why you do it. If the examination got a few interpretation, let's say a single heel raise or a Coleman block test, so you need really to add this extra information. Yeah, you really want to say, okay, Coleman block test, I want to know whether it's like if the hind foot is fixed or it's a forefoot driven, if is it flexible deformity or not. Yeah, so you want to describe what you're looking for in a Coleman block test. And again, don't ask questions. In clinical intermediates, it's a theatrical event. They call it in Fazal Ali's book and Banaskovich as well, they call it the dance. So to be able to do that dance, you need to kind of rehearse that choreography over and over and over again. The spine dance, the elbow dance, the hand dance, the CP patient dance, all those dances, you need to practice it a few times at least, so that on the day, you just like time to shine. You're not really thinking about your next move. Make an intro for the for the patient. There is plenty of time. Just build rapport. Hello, nice to meet you. My name is Nabil. I'm one of the candidates, or I'm one of the doctors. How are you feeling today? What was the day easy? Have you been finding everything okay? Just show empathy and show, because they will be there for hours, and they're usually having a painful condition where people just doing the examination over and over again. So just show that, it will definitely give you a higher marks. Take your history, ask about everything, show empathy, smile, nod, show interest in what she's saying, your body language, be very open. Um, it could be difficult under stress, but like I would say, just act like a CIA agent, convince everybody that you are not under stress. Yeah, just act like you're in your best form. Like you may inside stressed, but try to appear as if you're not. You need to do and perform all the relevant exam, but you need to mention all exam. For example, I had a pes plano valgus in my intermediates. And when I finished the foot and ankle examination, I mentioned that now I need to check the pulse, sensation, the other foot, knees, hips, and the spine. I said that while I'm looking to the examiners, and they said, that's fine, let's talk. Yeah. But it's a one sentence. You don't really need to, you won't do it, but it's for completion. You just mention anything that is relevant to that joint. And I can't emphasize enough, in discussions, please only answer the questions, don't go anywhere, because it's a very, very good opportunity on a boring day for them to be silly. Yeah. So don't try to go anywhere that you think it's important, for example, unless it's asked. So try to focus on what they want to know rather than what you want to say. Thank you, everyone. This is me for today. I hope that was helpful and useful. If you don't mind, please, you can scan the QR code to give me feedback. Your feedback is very valuable to me. And you can press on the link as well. It will take you to the feedback. Any questions?
اللينك مش شغال يا نبيل، بس الكيو ار كود اعتقد شغال.
I'll copy the link في الشات بوكس.
الكيو ار كود شغال كويس. عندي سؤال يا نبيل.
اتفضل.
في الأيام اللي هي بتاعت الشغل احنا يعني